Hi, I'm Dr. Jim Hoven, your host of the Difference Makers podcast. This is a place where people come together that are making a difference for those who want to make a difference. And that's you. We're bringing thought leaders together in a sense of fusion where ideas and concepts and personalities are all driven together into one place at one time. And this is no different. In this episode, you're going to see cool things from cool people making a difference. Hello and welcome back, Difference Maker. It is I, your host, Dr. Jim Hoven of the Difference Makers podcast, and I get a chance to spend time with cool people every week. You guys have seen it by now. You know how many people that are making a difference in the lives of their communities and even in the nation and across the globe have been on this show, and we are so blessed to have them. And today, I have a friend on with me. And this friend is not only a person that I just love being around, but he's also part of our team. He's in the business development side of our group here at Ramos Law. He's in our Grand Junction office. His name is Andy Keith, and today we have a really cool topic. Andy has a unique history that we're going to go into a little bit, but what we're really going to focus on is this connection between being a provider of healthcare, being a patient of healthcare, and being a doctor within the healthcare system. So it's a really dynamic and kind of crazy shifting that Andy's going to be able to talk to. So without further ado, I'm excited to have Andy on the show. And Andy, let's do some good stuff.
Looking forward to it.
All right. So you've been with us now, and you've been with our firm for a couple of years, actually, in total, with your wife being one of our attorneys, and now you being with us on the business development side. Before we go too deep into the conversation at hand, would you just share a little bit about yourself and your background with the healthcare system? Because a lot of people think this system is broken and it doesn't work for a lot of people, but you have in-depth experience into it. Can you just give us a little bit about your history?
Well, thank you, Jim, and for including me in cool people.
Oh, absolutely. Top of the cool list.
I appreciate that. I can start with my first dream job. I got a job with Pfizer as a pharmaceutical representative, and I did that for almost 10 years. Got to sell pharmaceuticals. I'm sure you've heard of some of them: Lipitor, Viagra, Celebrex. It was my first job that put me in the field talking to healthcare providers, and I was also with Sanofi after that, selling insulin. I was a diabetes specialist and got to sell insulin for Sanofi. I then moved into healthcare payer world.
And describe what that is. What does that mean for people who may not know?
Insurance companies, those paying the bills. And when I was with Pfizer, as an employee benefit, they had an educational benefit, and I decided to take advantage of that. So I got my online master's degree from University of Phoenix, and I have a master's in business technology management. And so that helped open the doors at Rocky Mountain Health Plans, which is an insurance company headquarters in Grand Junction. And I was a quality improvement advisor and got to meet with healthcare providers and help build quality improvement teams within their practice.
And so would that be designed to help them get better outcomes for their patients or more efficient results, or what would that look like?
Both, hopefully. In the evolution of the payer world, they're trying to go from volume to quality. And we were helping practices prepare for the value-added contracts that now exist, the value-based incentive programs that are built to help incentivize providers to give better care, not more care. So Rocky Mountain Health Plan was a certified PTO, which is a practice transformation organization, and we worked alongside and with CMS as they were experimenting with value-based programs.
And CMS is Medicare, for those that don't know.
Centers for Medicare and Medicaid Services. We shorten it to CMS. And I was able to work in a couple pilot programs with practices that were awarded grants to participate in value-based incentive models. And so I did that for several years. And then I became the lead quality improvement advisor for Rocky Mountain Health Plan value-based programs, which were based on building quality care teams, which, to answer your questions, which would help with outcomes and better results. but also would help in better care, less provider burnout, that sort of outcomes is what we were hoping for and achieved. Because each of the pilot programs we worked with, the abbreviations CPC I and CPC Plus have evolved now into what CMS calls the Primary Care First program, which is now national. And it was neat to be there on the ground floor in working with the cohorts, which were Colorado was one of the states where providers could apply to be in that cohort or that experimental value-based program.
And so when you talk about this, I think it's important. Again, people don't understand any of this. If they're, even providers, right? If they've not been part of a big system, they're more like, wait, I just have to see enough patients to meet my bills and, take home a paycheck for my family and all that kind of stuff. And patients say, every time I go to the doctor's office, it's so crowded. This is very unique to them. And I know that when I was practicing, it was on the horizon in the chiropractic field, but I don't even know if it's crossed into that domain as of yet. I haven't seen it from the guys and gals that I work with, but it's such an interesting concept to say, as an example, and you can help me clarify this for folks, but say someone has a bit of a complicated lower back pain with radiation into their leg and that kind of thing. What the system is trying to set up is, look, we think we'll save money overall if we give them really great care by saying, let's get good imaging, let's get good conservative care, let's get good medical management and pain management. And if we do all that right at the right time, that's going to save us money in the long term versus a short bout, a short bout, a short bout, a middle bout, and then a surgery over a period of years. Is that something how the system's designed?
Well, that would be quality.
In theory?
Yes, in theory. And medicine is such a big field, and there's so many, and as far as pain management and treating the symptoms instead of the cause, yes, it would. Let me talk about the quality and how it's measured. Because you said, with having a plan and dealing with it sooner rather than later when complications arise, that's the route across all the disease states. And measuring quality of care is difficult for healthcare providers. But as far as the payers or the health insurance companies, if they see real savings and positive outcomes. So instead of the pain patient, let's talk about a diabetic patient. A diabetic patient, if treated well, treated early, if the insulin is supplemented and the sugars are controlled, or hypoglycemia is controlled, you can avoid a lot of complications like peripheral neuropathy, which could end up with amputations, blindness, heart disease, heart attacks, strokes. If you treat the disease early, you can live a more normal life and not be faced with blindness or an amputation or an early heart attack in your life.
Right.
So how do you measure that early in the system? It's that diagnosis of diabetes, type 2 or type 1. And if you are worried about getting people through the door and you need your 30 visits a day, you're considering all patients equal risk for dramatic outcomes. But the diabetic patient has unique risk. So it's important that we know who they are, that population. And one of the things I would like to do when doctors, you're here to improve quality, I would ask, do you know how many diabetic patients that are in your patient population? And initially that was a hard question to answer, and you don't think it would be. But once you know that you have 300 diabetic patients, then you can measure the quality of care on that population. And there's several measures to do that. And one is A1C. How many of your diabetic patients, of those 300 patients, have their A1C under control? Mm-hmm. Or there's different debate on what that control is, but as far as CMS, or Centers for Medicaid and Medicare Services, it's an A1C of 9 or less.
Wow, it's pretty stout.
It's stout. Some that want tighter control at 7.
Yes.
But you'll see your patients that are up there with hypoglycemia and their A1C, their monthly at 3-month average sugar levels are up at 13, 14.
Ooh, wow.
And that's where they're those crystalline sharp sugar molecules are flowing in your blood system, creating havoc.
Super havoc on all the arteries and all kinds of tissues.
Yeah, the arteries of your eyes, the arteries of your heart, those at your fingertips.
Mm-hmm.
And I think diabetes in particular has made such strides in the last 20 years. I've intimately familiar. My eldest sister, she was a type 1 diabetic, and my father was a type 2 diabetic. And I remember as my father was going through some of the later stages of the disease, I felt, if he had taken his insulin, if he had done more, if he, there's a tendency to blame the patient sometimes. Mm. But back then, there wasn't long-acting once-a-day injection of insulin. There wasn't the simple testing. There wasn't the blood monitoring. We've come so far in 20 years in that area that I think it's fighting the stigma is tough.
Yeah, you're right. And I mean, even with you talking about your family history, this has hit home to you in becoming a patient. So we talked about the payer side, trying to say, hey, how can we work with healthcare providers to make them a little more sane and to keep track of what they're doing so they're not having any kind of wasted care or wasted healthcare dollars. But then there's the patient that's in there too, right? And as every provider will ever tell you, when we go into this field, it's because we want to help people. And when you found yourself, you knew all about the healthcare side, you knew all about the provider side, but then all of a sudden you had this debilitating back pain and knee pain and all that kind of stuff. So now you got into the system. So what was it like for you to now be in the system where you were, in one sense, you were part of the quality control measure that the insurance company was having to look out for, and then on the other sense, you were a patient in an office that you wanted to be well taken care of, but that they had other patients to see. How did that feel for you going through that?
It has always felt I have to walk a tightrope because I've always been the patient of a provider who also I'm working with in one form or another. And you mentioned the pain industry or the avenue. I've had a knee replacement and a back fusion in the last year, and I've needed them for decades. And besides the stigma involved, there is that treating the symptom, treating the pain as opposed to the cause. And there's a lot of that in healthcare across the board. Where does it hurt? And you put a Band-Aid on it.
Or a medicine or a therapy or whatever, right?
Well, a medicine, a therapy, when we're specifically talking about pain, that's a whole nother topic. It's a pain management using opioids has been a big topic. There's so many side effects and negative sides to just treating pain with opioids, addiction to opioids to begin with.
1,000% agree.
And what they do. So one of the programs I was working with, because being a chronic pain sufferer and also working with providers who are on the cutting edge, trying to pull away from the pain meds and get to the solution, I think one of the things I thought was most important to learn is there's pain and there's suffering. And physical pain comes from a cause, and it's funny. It's pain and suffering are two different worlds, and you can't treat suffering with narcotics.
Amen to that. Yeah, that's so. What a distinction that is.
But it's hard to. What did I even say? Suffering from chronic pain, and you have to define pain narrowly to treat it effectively. Then when I started to take my pain seriously, it was a much longer road than I anticipated. The conservative treatment, I can step back to my very first career. I remember introducing new drugs, new pharmaceutical products. Most physicians, they have a philosophy: start low and go slow. Do no damage. Start with the lowest dose and then move through it. And that's same with treatment. Let's start with treating. Let's try to alleviate the pain. Let's try to start with physical therapy.
Yeah, conservative, right?
Conservative and time to heal. But you need to also know when that's not working.
Right. And we were talking about this morning. What I found interesting is we were talking about history and physical is one part of treatment. And when I, as a doctor, would see someone, it would be like, okay, tell me about what's going on and how long has it been there and what was the cause, the mechanism. We'd go through all these different factors, right? And then we would come up with a treatment plan, and we called it initial trial treatment plan for a reason, is so that if we got a good response from it, then we know we're on the right track. But if it stalled or if it got worse, then we said, ooh, we better do something. And one of those things was imaging, right? Imaging is so important, whether it's starting out with X-ray, then MRI and or CT, and then it just goes up in complexity from there. And so when you have to look at that, right? If something's not working.
And you're drilling down with those series of injury and increasing the expense, obviously.
For sure, yeah.
But like you say, when does the imaging come in? And it should come in soon. Mm-hmm. Just my personal story with my whole right side hurt. And I remember it started with the knee X-ray. And yes, you do need a knee replacement. And then the hip X-ray, because I thought I also needed a new hip. But I remember the sports medicine surgeon saying, yes, but look at your back.
Yes.
It's not your hip, it's your back. And so then we went to the MRI of the back and saw the full damage. And so even then, fusion surgery was an option, but we wanted to take it slow. And we did pain treatments and injections. And it's how well those handle the symptom is how quickly you'll move on to the next step. Mm-hmm. And usually you would go through 3 cycles of pain treatments in that situation. But after 2, I thought for a few weeks of relief, I think it's time to go to the solution.
Yeah. And that solution involved for you, it ended up being a surgical.
Yes, I had to and it released my sciatic nerve and really has changed my life. I had a knee replacement in October and a back fusion in December, and I'm sitting here pain-free for the first time in decades.
Isn't that incredible? And that's really springboarded you into what you're doing with us, which is meeting with providers and having this relationship, because many of them you worked with on the medical side from your days in the health insurance world. And now you have this really unique landscape where you get to go into this whole scope. This is why I definitely am so glad to have you on the show, because you have this communication connection with a scope of providers from the very conservative to what we would call the very end aggressive, i.e. a surgery or nerve cauterization or those kinds of things. You've met with all these guys, but you're also experienced in how on some injuries, pain management through the conservative approach is everything you need. That's all you need. And then in other side, you have to take it to that level. So what is it when you're talking to a doctor, let's say, that is more of a conservative approach person, and you say, hey, just so you know, when we're working with you from our law firm, what we're looking for is a person that has what? What do you share with them in the sense of when we would, if our clients end up being with them, what does it look like from that scenario on the conservative side?
What are we looking for in a provider? That they care, that their values are aligned with our values. And when you ask a question, I think that every patient matters to them is one of the most important, which I find, because let me start by saying I'm on my 3rd career with the same customers.
So cool.
Yeah. So this round I get to tell the story of Ramos law. I was telling the story of whatever pharmaceutical products I was representing, and then the story of the payer or the healthcare insurance company I was representing. And now as a Ramos Law marketing ambassador, I get to tell the story 3 times removed to the same people, and they know I care.
Yeah.
They know that it's that I understand every case is different, but there's some similarities where we can help. And now with the personal injury world, we're talking helping getting medical expenses paid with auto insurance. You know, most providers ask if you have health insurance or not. And then there's the patients who have health insurance, but they've been injured by someone else. And most physicians don't understand that it's not their health insurance that would cover that. It's the at-fault driver's car insurance. And every physician I've talked to lately, a light bulb sort of goes off when they realize, well, you're right. But I don't really even worry about it. I do know when they've been in an accident, but if they have health care insurance, the health care insurance covers it. And I get to explain that's not the whole situation.
Right. Isn't that great that for people who have been injured, if it's outside in a sports injury or something, then there's a couple options. You have basically self-pay, or you have health insurance if they have it, or some variation of that, whether it's a third-party national beneficiary like Medicare, Medicaid, or something else. But then all of a sudden you've got these types of individual cases that you work with now and we work with here every day, which are those that have been involved in a personal injury situation where, there may be health insurance involved, and that can be helpful, but there can also be, like you talked about, from the auto carrier, whether it's medical payments or lien or all these other things, it just gives more options for that patient to have care. But the interesting thing that I find of that is, especially from, as you and I have kind of debriefed on all the meetings that you've been having, is that the freedom that these providers find when they're like, well, wait, there's a way that I can take care of these patients where if their deductibles are too high and they can't afford them, that if this person comes in, there may be another coverage source where I'm actually getting paid for the work I do, but at the same time, if this person's care would be limited through health insurance, maybe there's more here. I love that so much because it does give more open access to people who really need it.
Yeah. I mean, you nailed it. And it does remove barriers once the whole situation is known. I think personally, I know you know this, my wife is an attorney here. And so I've been in the personal injury world as a spouse of an attorney for about 15 years now. And there's some pearls that you learn when you see behind the scenes. And right now, one of the conversation I have with physicians is about their own car insurance, because you think of the collision and the damage and getting the car repaired, but your own insurance can help cover in a situation when someone hits you who has no insurance. I've heard almost weekly unhappy story, and it's sad in America, where if you're hit by a driver who has no insurance, there's no coverage. And then you fall back on your own insurance, and you have uninsured motorists or uninsured or underinsured motorist coverage within your own, and it's unfortunately optional. And most people don't even know. And I really have enjoyed asking attorneys, do you know what your uninsured, underinsured coverage is on your automobile insurance?
Yeah, the providers that you're talking to.
I owe for about 15 right now.
Isn't that something? And again, that's because a lot of providers that don't work with these cases every day. And I know because this is what's so fascinating. Like when I was doing our practice, we were very familiar with auto care, so we knew that. But in so many outside of, unless you treat traumatic injuries regularly, it doesn't matter the kind of provider you are, and it doesn't matter the education you have. If you're not treating that, you don't understand how all that works. And so one of the great things that I've seen with the providers, that the story that you've been able to share with these providers across the Front Range and up in Grand Junction, Grand County, is that two things. One, you're raising their awareness as to what's not only best for their patients, but what may be best for them, right? By asking these questions. But the other side is, how important is it that great providers know other great providers out in different disciplines. So for example, with me as a chiropractor, it was really important that I knew great medical providers that were GPs, but also that were surgeons and that were pain management. And when I can find a group that all works together, that they all know trauma, it'd be like you were talking about diabetes earlier, right? All the diabetes specialists, and then that can lead on to different kinds of specialists, whether it be nephrologists or cardiologists that all work with diabetes. That's what we're talking about in trauma. Yep. It's so cool that now surgeons and physical therapists and acupuncturists, massage and chiros and all these people can work together under the auspice of trauma. And that's what, I mean, every time you and I talk, it just inspires me about how this story is getting out.
Yeah, and listening to you there, it's a team, a care team, especially to get over a major traumatic injury. There's not just one healthcare provider. You as a chiropractor, you know the relief and treatment you can give and diagnosis. But what if that diabetic patient is the one who was injured? You know, the specials endocrinology, but their primary care is mostly treating that. But bringing a care team together for each individual client or patient increases positive outcomes.
By a bunch, right?
By a ton.
Yeah.
Yeah, like in this situation, in personal injury, it's a way of removing barriers to care. Because you mentioned, a win-win. I like to think win-win-win. It's for what's best for the patient, what's best for the client is also what's best for the providers.
Yes.
And I've never met a provider, a doctor, an MD, a DO, a nurse practitioner that hasn't wanted what's best for their patient. I don't know an attorney, especially in this building, who doesn't want what's best for their client. And so I'm saying win-win. These providers, when they understand a personal injury case, they already struggle with being reimbursed from insurance companies. And I like to drive home the difference between an insurance company and a car company. You can submit your claims to an insurance company and as you go, keep submitting these claims. Auto insurance, they pay once. Mm-hmm. And that's why we need to get a proper diagnosis, a care plan, and look into the future for this patient. What's it going to take to heal and become whole from this accident?
Right.
And so that's how we then hold the auto insurance accountable for that one-time settlement, or if it goes to court, judgment. Mm-hmm. Yeah. It's a different animal than health insurance.
Completely. And that goes back to what we talked about a few minutes ago too, I think, Andy, with saying that the providers need to have a great connection with each other, because what can happen is after a trauma case is if one person is just going down their road and, one provider is saying, hey, I'm giving this kind of treatment. Doesn't matter what it is. I'm giving this, and they don't understand what the other things are or what they could or should be alongside their treatment, they can do a complete disservice for that patient in that, like you said, this is basically a one bite at the apple to get them back to where they were, but all the way back prior to their crash. I mean, every bit of their functional ability, their pain relief, their range of motion, their strength, all of that. And now, if MedPay is a little bit different that we won't go into right now, but basically you got this settlement amount that is a total to get you all the way back. And if these providers aren't communicating, it can be devastating for the patient outcome.
Yeah, I agree.
So where is it that you see the most benefit that you bring now to these providers? So you go and meet with them. Where is it that now you've found your unique niche to help them go like, wow, I'm so glad that I met Andy, because it at the end of the day, like you say, all of us as providers, we just want to help patients. And when we find anybody that can help us do that better and make sure that we're not just doing it for free because we can't do that or we'll close our doors, that becomes a super big asset. So where have you found your biggest joy in all of this?
I'm still looking for the ultimate joy.
Oh, okay.
We're getting there. But bringing the win-win-win scenario alive for a provider, because representing healthcare insurance, it was helping them get reimbursed. They're all familiar with denied claims, lack of documentation, that sort of thing. And they struggle with reimbursement amounts. The insurance industry, there's what is billed, but there's what the insurance company will allow. And there's always a dissatisfaction with the providers and their reimbursement rates. And then you move it to CMS, Centers for Medicaid and Medicare, their allowable reimbursement has been going down.
Yes.
So physicians are sensitive about being reimbursed. And it's gotten to be a struggle with the big healthcare insurance companies. And I get to come and explain and share a scenario where those hurdles can be overcome.
Right. And that then opens up their practice too, right? Like at the end of the day, this is what I'd love for our clients that become patients of these providers, is that oftentimes too, these clients couldn't go see these trauma specialty providers on their own if it weren't for multiple areas of the ability to pay. And so it's really, I see it as, like you said, this win-win-win, this connection that forms between a patient and a doctor in such a way that the doctor has the ability to help a person that they couldn't have helped before, and that the doctor has a payer source that's going to secure them. Because like you said, as CMS rates go down, inflation, the cost of everything else goes up, and the doctor's overhead goes up. And so the doctor gets caught in the middle of this place of, do I have to treat more patients in order to get by? Or do I treat each patient with less care because I'm only capped at a certain amount? So whether I do one service or four, it's the same amount. By having multiple payment sources, it just opens up the ability for that doctor to do what's best for that patient. I think that's a beautiful thing.
It is a beautiful thing. And I think finding my joy is something I learned from Dr. Ramos. Before I started working here, it was the three essentials of a personal injury settlement or recovery. And it starts with, I'm drawing a blank.
Making sure that they have good medical care. That's going to be one of them.
Well, let me start with fault. There was someone at fault that created this injury. That leads us to the second. There's injury, an authentic injury caused by someone. And the third is coverage.
Yep.
Sounds simple. You get to the third requirement. Coverage is messy. And most providers just, you have health insurance, great. If you don't, you're going to have to pay cash.
Yep, or go to a different place.
Yeah, and it's more complicated than that, but it's also more simple.
Yeah.
Once you have the three and get to the coverage question, you have an at-fault party. You do have an injury that needs treating. And then when you start to discuss coverage, you find that a lot of people don't get treatment. Mm-hmm. They don't know their rights. Mm-hmm. They were injured by someone, but they also have a deductible or a copay, or they don't have insurance and they're not getting the treatment they need.
Right.
So I've been working with a client and a provider where I shared an example at their hospital where a patient stopped getting care because they couldn't afford the copays and the deductible, and then it was sent to collections, and that's a lose, lose, lose.
Yeah.
This is a client of Ramos that has an at-fault party with plenty of coverage,
right?
Plenty of liability coverage, but that coverage people don't understand, and physicians they haven't bothered to dig in. But there's many layers of coverage. And so that's why I like to start with their coverage, mm-hmm. because in Colorado, it's unique. A unique situation where if you want to drive a vehicle, you need $25,000 in liability coverage, $25,50, $25 for each person, and $50 for the whole accident. And I believe that's about 70% of the drivers out there get minimum liability coverage. Mm-hmm. And so that's $25,000 or $50 for the whole accident. And you have a car full of people who are injured and sent to the hospital. $50,000 is not
enough.
Not enough. But it's there where I stop and I pause. Those are the mandatory. And there's actually 20% on the road today who have no insurance.
Yeah, and I think it goes to repeat, bear to repeating. We've done this on other shows that we've done. You have to, when you're considering insurance, especially for when it comes to what you can control, like you can't control necessarily what your employer offers you on a health plan, but on your auto plan, you can control how much you're willing to protect yourself. It just has to be equal to what you're willing to protect the other guy. But I think one of the things, as we kind of tie this all together, one of the things that I see you being so skilled at in your ability to work with not only the providers, but the clients / the patients of the providers, is to help them understand that there is coverage that they should be getting prior to. And that's a big service that you provide for doctors. Help them to educate their patients on what to do before there's an issue, so that when they need it, if they need it, God forbid, that then they're taken care of with all these kind of insurances that we've alluded to today. But it really does make a difference in seeing how you're able to take that message and bring it to the hearts of people that you talk to in the business community, right? In your local relationships. Like, I can feel your passion, and I know that people watching and listening can too, of your connection to help the people understand in trauma, it's a different animal than it is if it's non-traumatic. And that goes into a whole different level if it was a personal injury situation as opposed to a sports injury or a slip and fall. They're all different. But when it comes to personal injury situations and trauma, knowing what the patient can and should do and knowing what the providers can and should do, that's what creates this win-win-win.
Yeah. And I've been a presenter. I've always want to share what I know, but I've found that listening has been the most important ingredient to these conversations, because especially a physician or someone who has children or leading a major business, this provider group I was at, he's like, we have 300 employees.
Wow.
We have one of our employees has been injured in an accident this week, I'm sure. We need our employees to know this. And I love when we take that leap, that it's not just for your patients, it's not just for you, it's for everyone. And we do educational opportunities with our partner groups. And that's what he was looking for me to do now, is come in and talk about their coverage, that last part of it. And you share the three essentials, and then are you covered, and what's the most important thing in your own coverage? And it's not your healthcare insurance, it's your auto insurance.
Right.
And that leads to, have you had experience? Because I always kind of let people vent, from being a pharmaceutical rep to being an insurance representative to now lawyer. People don't love meeting with lawyers, until they find about...
Until they need one.
Well, until they found out until they need one, yes. But hopefully you'll know one before then.
Yes.
So I get to share the story of a special lawyer, Dr. Joseph Ramos, who's trying to do things differently. And sharing his story is when you're sharing with a physician that our founding attorney was an ER physician for over a decade, and working with the courts as an expert witness, he realized, that the lawyers didn't understand the injuries. So he went back to law school. And I could talk about Dr. Ramos, but that opens the door to conversation and not presenting.
Yes.
And I had a CEO of a major provider who was like, oh, well, I went through this with my mother. And the car insurance, she had over $10,000 in bill, and the car insurance company offered her $1,200. And she would have taken it if she didn't call me. And that would have been that one payment. And it wouldn't even have covered her first visits. So there is that. And he's like, you could see the lights going off. It was with his mother. But I think we all probably have an example in our family of someone who was hurt in an accident.
No doubt.
And that person needs to know their rights. And if they don't know, sometimes they don't get the health care they need.
Right.
Because I'm talking to a lot of providers who don't understand that they're not seeing, people aren't coming to them, not just because they can't afford it, but because they've been hurt and think they need to pay for the health care for the injuries that were caused.
Yes.
It's a different model. And when you get to that, getting to share the coverages, there's good lawyers worth themselves in gold when they're needed, because they will explain the levels of coverage. And you need to go through those levels to find out. And it does take time. But when the attorney can work with the healthcare providers and get the bills up front or as quick as possible, we can determine the damages. Then we can communicate with the insurance company to start working through those levels of coverage.
Right.
Because a lot of providers, they just had, oh, well, if we're looking at a car insurance settlement, we're talking 3 years from now. And I was like, well, without cooperation, possibly.
Yes.
Because I know getting the health care bills for a client is tough. You would think having a hospital would be able to just, send you the bills because they want to get paid. And no, that's half the challenge that I've seen is collecting the expenses to create the authentic damages that we're going to present to the insurance company for their one-time either settlement or go to court for judgment.
Absolutely. And all this starts getting into deep waters and complex waters. And that's why people, and you've done a masterful job at sharing this already, but people need to know if they've been in a crash, what to do. And in our case, we tell them, look, you're better off to talk to an attorney. And for an attorney, at least our attorneys are basically, they're told, if we can't add more value to a case than what you could get on your own, we're not going to take that case. It's not worth the time it would take for you, nor is it worth the time it would take for us in order to help you. Like we'll tell you, if we think that you're this close to having it on your own, we'll just tell you, look, write a letter that says this, this, and this, and you'll be able to get that. Now, if you can't as a person do that or don't want to do that, or if it becomes more complicated in that, that's where then we would jump in. But I think it goes to your point to say having great care is one thing. Having great advocates is another. And if you're going to be a great patient, it means you need to know all that landscape, and you're not going to know that on your own. So, man, I can't tell you how much I appreciate you, Andy, coming on and sharing your story and the job that you do and the passion and the heart that you give. I know that it comes across like crazy, to our audience, whether they're listening or whether they're watching. But I would just like to, again, say thank you for what you do. And, whatever people have questions about, how could they get a hold of you and reach out to you if they had questions, whether they're up in Grand Junction or anything else, people that have heard your story and want to learn more?
Oh, well, I'm on every platform, but I think ramoslaw.com is the place to start.
Yeah, go to ramoslaw.com, look for Andy there, and he'll be there to answer your questions. And if you found value in this, please do me a favor. Share this with someone who may not have heard this. If you've known someone who's been in an accident, even if it wasn't a recent one, and they're still hurting, reach out to us. Let us know. Maybe there's something that we can do, whether it's to give you a referral of somewhere or just some advice, or maybe it's to talk to someone. But don't let these things go. Be a difference maker in your own life and in the lives of others. Now, also, if you like this and you haven't subscribed yet, please do. There's a little bell or dingy you can click on that'll help you with grabbing some of the show notes, all this stuff. And I'm mixing all these things together in the digital soup world. But I just want to say that we appreciate you. We thank you for following us. 200 and whatever episodes, 220 or 30, whatever it is, you guys have been with us the whole way. And without you, there is no difference maker. So on that note, thank you. Keep making a difference. If there's anything that you would like to hear about, any topics, any guest speakers, please, you can email me directly, jim@ramoslaw.com, and we'll do our best to get those on. Otherwise, you have a great week. Know that you're cared about and keep making a difference.